Hey, welcome back. This is Advanced Patient Care Theory 2, Unit 4, Part 1, Endocrine. Let's focus for this one on diabetes. So there are a bunch of different major endocrine glands. Hang on a second, I got a sneeze coming. Okay. All right, so parathyroid, thymus, pancreas, which is what we're going to focus on, the adrenals, and the ovaries and testes. And so just as a review, as you know, the pancreas produces two main hormones, insulin, which lowers blood glucose and moves glucose into the cell, and glucagon, which produced and secreted by the alpha cells of the pancreas and raises blood glucose levels by breaking down glycogen to glucose, and glycogen is stored primarily in the liver and skeletal muscles. The pancreas also produces somatostatin, which lowers insulin and glucose levels when those hormone levels are too high. And also the pancreas also produces digestive enzymes, which is its exocrine function. And there's a link to some additional information. So the three main cells, the alpha cells produce glucagon, the islets of Langerhans contain beta cells, which produce insulin, and then the delta cells, which produce somatostatin. And so insulin is produced by the beta cells, the islets of Langerhans, and the islets make up only about 5% of the pancreas. And diabetes is marked by two things. One, a decrease in insulin production and a cellular resistance. And in type 2 diabetes, we see one of the bigger components is the cellular resistance to insulin, where the insulin production may actually be normal, but the resistance to insulin is elevated. And there's a lot of research now around not just diet, but even fasting, and how effective fasting can be on decreasing the cell resistance to insulin. So there's been some research around fasting for 24 hours 3 times a week. And there's been some interesting research around fasting for a total of 72 hours, which not only decreases resistance to insulin in the cells, but also apparently regenerates your immune system. So not something you can easily do when you're working shift work, if you can do it at all. But so insulin we need to regulate blood glucose levels, and it's a dominant hormone when glucose levels are high, and it basically makes the cell more permeable to glucose. And sometimes, just out of interest, when the cell becomes more permeable to glucose, electrolytes will also travel through the openings of those cells across a concentration gradient or an electrical gradient. So, for example, one of the treatments for diabetic ketoacidosis, for reducing potassium levels, because hyperkalemia is common in diabetic ketoacidosis, is to give insulin, because insulin does two things: it lowers the blood sugar in hyperglycemia and a diabetic ketoacidosis, but also causes a shift of potassium from outside the cell to inside the cell, and that decreases the serum potassium levels, as you might recall from our discussion from last semester. So it also converts glucose to excess glucose to glycogen, and eventually that gets converted to fat if it's not used. Type 1 diabetes, you're all familiar with. It's an autoimmune disorder where the body's immune system attacks the beta cells and destroys the beta cells. And it's the result of an absolute or relative deficiency in insulin. And these patients become insulin dependent. So they're insulin dependent diabetes mellitus. We usually categorize diabetic patients as either IDDM or NIDDM, with the one exception that if they're type 2, then we call them, and they're also taking insulin, then we call them type 2 IDDMs. So age onset is typically under 40, and the average age of onset is 14. So, when you look at your children, that's one of the things you always worry about is will they develop diabetes between now and by the time they're 20 or so. And there's a genetic component to it, but there's also, because it's an autoimmune disorder, you always worry that if they get some sort of illness and they go on antibiotics, that there'll be opportunistic bacteria that will attack the beta cells in the islets of Langerhans, and your kid will end up as an insulin-dependent diabetes. Maybe that's just me being paranoid, as a medic and a parent. But so type 1 is also referred to as juvenile onset diabetes, but it's not always kids who develop IDDM. But these kids almost invariably have a lifetime dependence on exogenous insulin. Type 2 occurs later in life, as you know, and there's a decrease in insulin production. There's a cellular resistance to insulin, and sometimes referred to as age-onset diabetes, typically non-insulin dependent diabetes. These are typically NIDDMs, rather. And it's significantly more common than type 1. We don't deal with type 2 hypoglycemic patients very often. The vast majority of times when we have hypoglycemic patients are type 1 diabetics. I'm sure you've had that experience too. But type 2 is significantly more common. And most often you'll get type 2 diabetics who are hypoglycemic because they're on a new medication that competes with their diabetic drug for I'm having a TIA here, for the liver enzyme that breaks down their diabetic drug, the cytochrome P450 enzyme. So cytochrome P450 typically breaks down anti-diabetic drugs, but also breaks down antibiotics, certain antibiotics. So if the patient's on a new antibiotic, the bioavailability of their diabetic drug may be greater, and consequently their blood sugar may end up lower. So if you ever encounter a type 2 diabetic who's hypoglycemic, review their drugs and fill out a CREMS form so that they get some attention in the next 24 hours and a review of their medications, because they may have to adjust their diabetic drugs. I've seen this 2 or 3 times, and we filled out a CREMS form and got them some attention. One of the leading causes of type 2 diabetes is a genetic predisposition to the disease, but weight also plays a significant precipitating factor. So typically, as I said earlier, we break patients down into one of these 3 categories: IDDM, NIDDM, or type 2 IDDM. The patients are on metformin and they're on insulin as well. Long-term complications of diabetes you're all familiar with: retinopathies, cataracts, hypertension, progressive renal failure, early coronary artery disease, peripheral vascular disease, and that can lead to, particularly with type 1 diabetics, can lead to complications with peripheral perfusion and amputation of limbs. Neuropathies, both peripheral and autonomic. So neuropathies means dysfunction of nerve or nerve degeneration, nerve dysfunction, and maybe decreased sensation of pain, increased risk of infection. And infections take longer to heal. So hypoglycemia is the most common medical emergency in diabetics that you and I respond to. It happens acutely as opposed to hyperglycemia, which is more of a chronic thing, happens over days to a week or so. And most often occurs because the patient took too much insulin or took their insulin without a food intake, maybe exercise without taking enough food. So these are questions that we need to ask once we've given them D50 and woken them up. If they're on oral hypoglycemics and prescription drug, plus decreased food intake. That may be another cause, or combination of insulin and oral hypoglycemics. As I mentioned earlier, taking a new prescription drug or over-the-counter drug, an antibiotic or other, which is also metabolized by the cytochrome P450 system. It's one of the reasons why people are told for many drugs don't drink or eat grapefruit juice, because it's metabolized by the cytochrome P450 system, and that increases the circulating volume of the drug that they're taking. So the clinical presentation for hypoglycemia, as you well know, is confusion, agitation, to leading to coma, anywhere from GCS of 3 to 14 in terms of management. General weakness, diaphoresis, combativeness, restlessness, glucose levels less than 4 millimoles per liter in adults, less than 3 in children under the age of 2. And we may see hypoglycemia, or the differential for hypoglycemia is hypoglycemia, ETOH abuse, stroke, CNS infection, post-ictal patients, dehydration, hypothyroidism, renal failure, hepatic failure or hepatic encephalopathy, psychosis, and so the key is with any altered LOA that we check the blood sugar level to rule that in or rule that out as a cause. In terms of management, so we look after the airway, but important to remember that if you're dealing with a patient who has a GCS of 8 or less and you're thinking about intubation, look for an underlying cause first. Right? So we check blood sugar level, of course, that's number one. We consider hypoxia, we consider other causes of altered LOA before we put a tube in place. And so we're looking for something reversible. So if we need to manage the airway, we just manage the airway with PPD with a BVM. SpO2, O2, PRN, assess blood glucose levels, ECG monitoring, IV. Big is better, because if you're giving a viscous solution like D50, it goes in slowly. Now the needle at the end of the preload is pretty small, so the speed at which you're going to be able to administer D50 is going to be limited anyway. But patients should have at least a size 18 if they're an adult. You can certainly get D50 into a 20 gauge, but it's easy, a little bit easier with an 18. So IV dextrose. I'm wondering now if we're going to start carrying D10W. There's been a lot of criticism about giving D50 to diabetics. That one, we go beyond what they need for dextrose, and you've had this experience, I'm sure, where you've had a hypoglycemic diabetic, you bolus of D50. Just out of curiosity, how many of you given a diabetic patient a bolus of D50?
I have.
Presumably it would be just those of you who are IV certified. Okay, good, yeah.
We had one jet puke on us when we woke him up a couple weeks ago, actually.
Oh, that's too bad.
Yeah, it was lovely.
It's such a routine thing right now. I don't know if I told you the story, but years ago when I was working air and there were very few medics anywhere in the province, there were fewer than, I want to say, 30 ACPs in the entire province. And we responded to a car crash, and there was an elderly lady who was extricated, and she was completely unresponsive. And I thought checking a blood sugar is stupid on her. She's a trauma patient, but I was told to check her blood sugar, so I checked her blood sugar, and I checked her blood sugar, and it was 1.2. So I started an IV, and I gave her dextrose, and the medics and the firefighters were just completely blown away when she woke up. They were totally and utterly beside themselves. It was like a miracle. It was the best thing ever. Anyway, it was cool. Nowadays, it's no biggie anymore. But in the old days, let me tell you. So if yeah, so interesting. In British Columbia, they don't give bolus of D50. They carry D10W. In Australia, they give D10W as well. And they basically start a line, start infusing it, and when the patient wakes up, they check a blood sugar. If the blood sugar is good, they discontinue. So they might give, 100 mLs of a 250 cc bag, and then be done with it, and just get the sugar up enough to be normal, and then they, get them up, get them something to eat. And you're not dealing with a blood sugar of 14 after a bolus of D50. So in the absence of an IV, glucagon would be the second option. IM would be our directive, but it can be given sub-Q or IM, but we give it IM, and because it works a little faster. Indications for management of hypoglycemia are pretty straightforward. The patients are agitated, altered LOA, or a seizure, or symptoms of a stroke, and the conditions just LOA altered, and they're hypoglycemic. That's it for both glucagon or dextrose. The contraindications, allergy and sensitivity, applies to every drug that we give, and glucagon, pheochromocytoma. Now, just out of curiosity, has anyone here had a patient with pheochromocytoma? I have not, I can tell you that.
I've had one.
You have, really, eh? Okay, so interesting.
Yeah. And they knew all about it, and they knew all about glucagon, so don't ever give me glucagon.
Yeah, cool. So there was a PCP crew at Appeal, and they had a patient who was being investigated for pheochromocytoma, and so they chose not to give glucagon. But patients with glucagon are less likely to be hypoglycemic and more likely to be hyperglycemic because they don't have an issue with insulin production, but what they do have is these fight or flight responses, these catecholamine surges, and so they tend to have labile blood pressures, and the symptoms they may experience are things like feeling flush because they get hypertensive and then their blood pressure comes down, they get tachycardic and then their heart rate comes down, so they have these really labile vital signs, and that makes them feel unwell, and so they go in to get investigated, and one of the tests that they use to see if they have pheochromocytoma is they give them glucagon, and sort of a bit of a challenge to test them out, because glucagon will cause excess adrenal gland secretion of catecholamines, and are not necessarily excess, but a discharge of catecholamines, and so they're assessed with glucagon. And so if you get someone who's been having those kinds of symptoms and has not yet been diagnosed with pheochromocytoma and hasn't been told they're being investigated for pheochromocytoma, you should be suspicious that might be the underlying cause, and you're probably better off to patch your base hospital doc before you give them glucagon. Just explaining the kinds of labile vitals they've had recently, and they're being investigated, but they're not certain what it is. So for dextrose, just a review of the medical directives. So if they're under 30, they get D50. And how do you convert D50 down to D10 rather?
Of D50, and then fill the rest with saline.
Yeah, so get rid of 40 and replace it with 40 of saline. Good. That gives us D10, and the dose is 2 mLs per kilo. That's probably the easiest way to remember, or 0.2 grams per kilo. And we give that, and then 10 minutes later, if they're still hypoglycemic, we give it again. Between 30 days and less than 2, they get D25, and that's fairly straightforward. You just empty half of your preload and refill it with saline, and they get 2 mils per kilo as well, and that works out to 5.5 grams per kilo, and same dosing interval. and then 2 years of age or older, they get D50, and, at 1 ml per kilo. So the easy thing to remember is 2 mils per kilo, 2 mils per kilo, 1 ml per kilo for anyone 2 years of age or older. Fairly straightforward. One of the things they don't talk about is insulinomas, and insulinoma is a relative contraindication. So insulinomas, relative contraindication for glucagon, that is. Glucagon may decrease their hypoglycemia or may exacerbate their hypoglycemia. So I would probably patch with someone who's got insulinoma, but there's no mention of it in your medical directive, so no one can criticize you for giving glucagon in a patient who's got a history of insulinoma. So here's a question for you. An 18-month-old weighs 13 kilos, and what concentration are you going to use for dextrose? And how many mLs per kilo? And what does that work out to in grams per kilo? Feel free to write on the board or write on the slide. Is it grayed out? Oops, that's not what I wanted. Hang on. Trying to get rid of this. All right. I'm waiting for your answers, guys. Okay, so Andrew says D25W, good. And how many mLs per kilo do they get? Okay, so they get 2 mLs per kilo, good, and 0.5 grams per kilo, good. Okay. Alrighty, let's move on. For glucagon, if they're under 25 kilos, they get 0.5 milligrams IM glucagon. And if they're still hypoglycemic in 20 minutes, they get a second dose. Chances are a second dose is going to be of no benefit. The question you have to ask yourself is, why is their blood sugar still low after a single dose of glucagon? Is it because they have diminished liver function? Hang on a second here. Or because they have starvation or alcohol abuse. We had a patient who was a crack cocaine user. He was about 5'11" and I would say maybe 45 kilos, and was hypoglycemic, and we couldn't get a line on him. His veins were just really sclerosed rather, and we gave him a dose of glucagon. It didn't touch him at all. Managed to start an IV on him eventually and gave him D50, and he was fine after that, but glucagon was just not going to work with this guy because he was suffering from starvation. So sorry, clinical considerations. So if the patient responds to dextrose or glucagon, they can receive oral glucose or simple carbohydrates. I always, if they cancel, I always stick around and wait for them to have a meal. Go ahead, Charles.
Just, I've had a couple of cases that there's been some unusual characteristics related to the kidneys. How would you change the way that you treat a diabetic patient hypoglycemia when you're either suspecting or have a known history of renal failure? Does that change the amount of D50 or the concentration you'd like to be giving? And yeah, if you could just, because it's come up a couple times for me, and I just want to get an expert opinion on how that might change your practice a little bit.
So the short answer is no. They get treated like any other hypoglycemic diabetic. Renal failure, no renal failure. It's a little bit different from other drugs that we're administering because dextrose is a substrate, right? It's not an active metabolite like other drugs, where liver failure and renal failure is a bit of a concern because of the increase in the circulating medication. So with D50, it's really not a consideration. Hopefully that answers your question. So with type 1 diabetics in particular, IDDMs, you're most likely going to treat their hypoglycemia if you're giving D50. If you're giving glucagon, basically you're transporting. But you give them D50, you wake them up, they refuse transport, you discontinue the IV. And really what you have to do is your due diligence when you cancel them off. I think it's a good thing that we're canceling them off. This is good for the healthcare system. It reduces the cost. I was talking to an ER doc and I said, what do you in your estimation, what would it cost the healthcare system if we brought these now normal glycemic patients into the ER for assessment? Because we used to do that for a long time. We used to do D50, wake them up, and we transported all of them. And he was saying that in his estimation it would cost, and this was back in the 90s, it would cost about $2,000 for him to get processed through the ER and then sent home. Because they keep him there, they give him a bite to eat and do vital signs and not much else, and then send him home. So that was in the 90s. Now we're probably looking at $500 or more, or a grand, or sorry, not $500. We're probably looking at maybe $3,000 to have that patient go to the ER. So canceling is really a good thing for the overall healthcare system, in my opinion. But we have to do our due diligence, right? We have to do an assessment of capacity, which means that they're awake, they're oriented, they understand what's happened, they understand the risk to them should they become hypoglycemic again. They're with an adult. We watch them eat. I usually get somebody to make a sandwich. Usually they don't want to eat. They really don't want to eat. And but we watch them eat a little bit, and then we have them sign off. That's all good. I'm assuming all of you who are giving D50 have had sign-offs on hypoglycemic patients. Would that be fair? Yeah, so you want to think about a refusal post-treatment. So what's the likelihood of this reoccurring? Now, if it's a type 2 diabetic who's on oral hypoglycemics and is also on a new drug, then the risk of this reoccurrence is pretty high. And this is why if they do cancel, we need to do a CREMS form for them. Otherwise, we should probably be trying to persuade them to go to a hospital, just given the fact that hypoglycemia is unusual in a NIDDM patient. Peanut butter sandwich, okay, and cheese slices. Peanut butter and cheese. I know some people like that stuff. It doesn't do it for me, but so we rule out the risk of recurrence, or try to rule out the risk of recurrence, or gauge the risk of reoccurrence, do a patient's assessment of capacity in the back of the form, and ensure you document that the patient understands the risk for declining transport, ensure a caregiver is there to care for them, watch them eat some carbohydrates, and document all of that stuff in the remarks section, and then you should be covered. What's the risk associated with giving D50 to a newborn? Anyone know? Not cerebral edema. No, excess fluid can cause cerebral edema, although I suppose D50 could cause cerebral edema, because that is a lot of fluid. or potentially a lot of fluid. Although if you're giving a ml per kilo, maybe not too bad. Yeah, the tonicity is an issue, and that's the main issue, and it can cause intraventricular hemorrhage. So you think of the ventricles in the brain, it can actually cause intraventricular hemorrhage in the brain in a newborn. So so that's the reason we don't give high concentrations of dextrose in newborns or in kids under 2. So that's it for that. Any questions on this topic so far before we move on to hyperglycemia, the next round?